Welcome to Chapter 3, Medical, Legal, and Ethical Issues. This is one of the most really important chapters we're going to cover in the EMT course because it directly impacts how you provide care in the field and really how you're going to protect yourself legally and professionally. As EMTs, we're often the first ones on scene, and that means we're responsible for making quick decisions, really that must align with the law and ethical principles. Um, this chapter is about really understanding your responsibilities, your limitations, and just how to ensure your actions are both lawful and compassionate. So let's begin with of course, the National EMS Education Standards. As an EMT, you're really expected to demonstrate a fundamental knowledge of EMS systems, right? This is going to include legal, ethical frameworks in which we're going to operate under. The first section emphasizes the preparatory knowledge you need to deliver safe, effective care. That includes understanding the scope of your practice, protecting patient rights, and maintaining professional behavior really at all times, no matter the situation. You'll see that these legal and ethical components really aren't just in theory or theoretical. They apply to every single patient. Now we get into more of the specifics. In this chapter, you're going to learn about consent, okay, and when to obtain the consent, and what to do when which is one of the more tricky situations, is when a patient tries to refuse care, which in some situation is their right. Okay, also going to learn about confidentiality, including HIPAA, how to handle DNRs, advanced directives. We'll touch on the criminal and civil liabilities, the importance of preserving evidence and civil liabilities, um, and really the statutory responsibilities that come with our role as EMTs. Whether you're documenting a call or documenting just a simple call or responding to a crime scene, these are going to be critical competencies that you must know and pretty much know how to apply correctly. And here's the rest of the competency list. We're going to move through this chapter. We're going to talk about the mandatory reporting obligations because as an EMT, you are a mandated reporter. For example, when you suspect abuse, injuries, drug-related injuries to an extent, but more talking about child abuse, elder abuse, and certain communicable diseases. We have to report that as well. Certain types of violent crimes like shootings. We also be introduced to core ethical principles and really how they're going to guide the decision making in really these emotionally charged or morally ambiguous situations that you're going to find yourself in. Lastly, we're going to talk about the end of life issues, okay? So, which you're going to encounter in the field quite often. And unfortunately, it's going to come without warning. And you're really not going to know what to do and how to interact with these patients until the time comes. But in this chapter, hopefully, you're going to learn how to handle all of these calls with just professionalism, compassion, and legal awareness, more or less. All right, so emergency medicine really begins with the principle of do no further harm. Okay, so but as EMTs, we're going to have to go beyond that. Okay, we initiate care, we stabilize patients, and we're going to transport them safely to get definitive care with the doctors and the nurses at the hospital. That really gives us a lot of power and responsibility. So this chapter really is going to prepare you to avoid the legal problems by really just acting in good faith. Okay, so that means you're going to follow the appropriate standard of care and just treating patients with respect. But even when we do everything right, we may face more tough questions in situations like what if a patient refuses treatment? What if a patient or a parent orders you to stop treating a child who appears abused? What if your partner breaches confidentiality on social media? We're really going to have to explore these gray areas so you're ready to make sound decisions really in the moment. Ones that are going to really keep your patient safe, but also protect your professional integrity and liability. So let's start with one of the most important legal and ethical obligations in EMS, and that's going to be obtaining consent. Okay. So as a medical provider, you need permission to actually treat. So in the simplest terms, consent is, just like I said, is a patient's permission to essentially receive care. But it's not as simple as a yes or no situation, right? Consent is the legal and ethical foundation that gives you the right to assess and treat someone. And without it, you could be liable for criminal or civil penalties, including charges of assault, battery, false imprisonment. So now, for consent to be valid, the patient must be a conscious adult who is rational, capable of making informed decisions about their own health. And that's really known as having what we call decision-making capacity. Okay, it's a term we use in healthcare to describe whether a patient can understand the information that you're giving them and make a decision based on it. So to be clear, just because someone is injured, it doesn't mean they lose the right to say no. A competent adult has really the legal right to refuse care, even if the decision is life-threatening. The principle of this is really grounded in what we call patient autonomy, the right of individuals to make decisions about their own medical care. So, how do we know if someone has decision-making capacity? We're going to look at things like are they oriented to person, place, time, and event or reason? Okay, so that's what we're going to call ANO times four. Are they under the influence of drugs or alcohol? I'll edit that out. Do they have a head injury or a medical condition that really impairs their ability to think clearly? Do they understand that what you're saying and ask appropriate questions in response? If you determine that the patient meets these criteria, then you must get their permission, their consent before you're able to proceed with any type of interventions or treatment. Now you can ask questions, of course, but in terms of actually taking them to the hospital or doing any type of intervention, they need to have that consent. So, let's talk about the foundation of what we do, a valid consent. Okay, and that's going to be what we call informed consent. Okay, informed consent means that the patient is not just saying yes, but they understand that what they're saying yes to. Right? You need to explain the nature of the treatment you're offering, including the risks, the benefits, and really any alternatives. As well as what could happen if the patient refuses, which is a big tactic we're going to use to try to get them to consent to just letting you treat them. But that doesn't mean in a 10-minute lecture on medical terminology, like what you would do. It means really communicating clearly, respectfully, in a way that the patient can understand. Okay. For example, instead of saying like I'm going to auscultate your thoracic cavity, you might just say, I'd like to listen to your lungs to check your breathing. Is that okay? If your patient agrees after you've explained the situation, that's informed consent. Okay. Now, we rarely have really the luxury of written consent forms in the field. So your documentation is everything. Okay. So when you're completing your patient care report. Also, write in this PCR that the patient gave informed consent, and whenever possible, have a witness, like a bystander, family member, your partner, fire, law enforcement, someone who can actually verify it. It's also important to understand that a patient can give consent to certain treatments and refuse others. So maybe they'll let you check their blood pressure, but not transport them to the hospital. And that's their right, and you need to respect it, even if you disagree with their choice. And a key point here is that the patient's right to refuse treatment is going to be discussed later in this chapter. But remember that informed consent and the right to refuse, if you refuse care, go hand in hand. Both depend on your ability to assess whether the patient truly understands what's at stake. So here we have express consent. So it's also called actual consent. It's when the patient actively indicates they want care. So either verbally or through physical kind of action, so like body language. So let's say you ask a patient, "Can I take your blood pressure?" And they say yes. That's what we call verbal express consent. Okay. Or if they don't speak, but they roll up their sleeve, extend their arm, that's nonverbal express consent. Either way, they're clearly like signaling that they understand that what you're doing and they agree to it. But the thing is that for express consent to be legally valid, it must also be informed. Okay, that means you need to explain what you're doing, what is it for, and are there any risk or consequences associated with it. A patient must have decision-making capacity. It must not be coerced or confused. Um, so here's a little pro tip. You don't always have to say the words, "Do I have your consent?" Instead, just work it out into your conversation. Like for example, hi, I'm with the ambulance service. I'm with AMR. You call 911. We're gonna check you out and take your vitals. Is that all right? That's an easy, great way to just start your introduction with that patient. If the patient just simply nods or verbally agrees, boom, you've obtained express consent. Always document that interaction. If you're ever asked to defend your actions in court, your narrative and that PCR, that patient care report, is really what's going to protect you. And if there's ever a dispute, having the witness who heard the patient agree or saw the patient like give some nonverbal agreement to the treatment, that can make a big difference in the whole legality of it all. So, what happens though when a patient is unable to give consent, right? That's where implied consent comes into play. Okay. Implied consent is a legal concept, really, that allows EMS providers to treat a patient when the patient cannot make an informed decision, and when delaying treatment could cause harm. So that's going to include patients who are unconscious, disoriented, or altered due to a medical condition, severely intoxicated, or just suffering from a condition like a head injury or a stroke. In these situations, the law actually assumes that the patient would actually consent to treatment if they were capable of doing so. This is also referred to as the emergency doctrine. It applies only when a serious medical condition exists, okay? One that poses like an immediate life threat to life or limb. But let me emphasize, you should never really invoke implied consent unless the emergency is clear and urgent. So if it's not obvious that the patient condition is critical and that they can't clearly refuse, the use of implied consent could be challenged legally. But more or less, if a patient is altered or in any capacity, your job is to treat and take them to the hospital to get checked out. Okay, so don't get discouraged by like trying to figure out, ooh, do I treat this patient? Do I not? If they're altered in any way, you're typically going to transport. Um, So if we continue, so a little bit more limitations with this implied consent. First, if a patient like regains consciousness and now appears to have decision-making capacity, implied consent no longer applies. So if someone like overdosed, for example, and was unresponsive when you arrived, but now they're awake and alert after you treated them, you now have to switch back to getting expressed, informed consent moving forward. You can't keep treating them under implied consent. Always making an effort to locate a family member, a legal guardian before proceeding. If it doesn't delay care, that's always a good idea, a good step to go into. But again, only if it doesn't delay the treatment. A good example is this: if a child is critically injured, critically ill, and a parent is nearby but not yet on scene, you can still provide life-saving care, but notify and involve the parent as soon as you possibly can. Because again, if they're a minor, the guardian or the parent is going to be the ones in charge of the medical well-being of that specific patient. Another example would be imagine like an elderly patient who is confused after they fell. Okay, you suspect some type of head injury, but they're saying they don't want care. If their mental status is impaired, you can invoke implied consent, but you must document your observations like very in detailed, thoroughly, and that includes what they said, how they acted, and why you concluded that they couldn't make any informed decisions, right? Finally, always consult with medical control. So contact base if you're unsure whether implied consent can apply to the specific situation. Remember, medical control is always there as like your backup, just in case you're not sure what to do. They're the safety net for you. They're really going to help guide your decisions and your documentation of that consultation will protect you legally. Now let's talk. Oh yeah, let's talk about involuntary consent. Okay, this is going to apply in situations where the patient really cannot legally make medical decisions for themselves, and someone else must give consent on their behalf. Okay, this typically includes individuals who are mentally ill, experiencing behavioral health crisis. Those are who are developmentally challenged or delayed. Certain individuals under incarceration or police custody, rather. For these patients, consent should be obtained from a legal guardian, a conservator, an authorized decision maker of some sort. But often in the field, that person isn't really available to you. In such cases, many states have protective custody laws, which allow law enforcement to authorize the transport and treatment if the person is at risk of harming themselves or others. Okay, that's what we're going to call a 5150 psychiatric hold. For example, if a person with, let's say, schizophrenia, right, is wandering into traffic or becoming combative, the police can actually place them in protective custody, and you can proceed with treatment based on what we call, again, involuntary consent. There are also specific rules for incarcerated individuals. Those are individuals in prison. So a prisoner who is conscious and capable of understanding their situation does not automatically lose their right to refuse care, but you must still assess their capacity and proceed accordingly based on what your assessment is telling you. In some cases, a jail or prison official can make medical decisions for an inmate. But again, this really depends on the local law and your specific circumstance. But again, when in doubt, just involve medical control. They'll help you determine whether involuntary consent applies and really just provide guidance so you can document in your patient care report. So again, let's revisit this. So when treating minors, okay, the rule around consent becomes even more specific, and they can vary again by state. But generally speaking, a parent or legal guardian must provide consent for a medical treatment of a minor because minors are not considered legally capable of making their own healthcare decisions. This is going to apply in most routine or non-emergency cases. However, there are several exceptions. Okay, for example, some states allow minors to consent for themselves under certain circumstances, such as if they're emancipated. That means they're legally treated as adults due to being married, serving in the military, or just being financially independent. Um, if they're parents themselves, so if a minor who has a child, they can usually make medical decisions for that child and sometimes for themselves. Um, Living away from their parents and being self-supporting with or without formal emancipation orders. You may also encounter situations where teachers or some type of school official, like a principal or a school nurse, are allowed to act in a loco parentis, which really means that in place of a parent. This means that if a child is injured at school or camp or a field trip, the parent cannot be reached. A teacher or the administrator may give consent for emergency care. But still, whenever possible, you should always attempt to really contact a parent or guardian. But again, if it's a true emergency and no authorized adult is available, then implied consent would be applied to the situation, and you must treat the child to prevent death or injury. Okay. To continue on with our minor discussion, you should never really withhold life-saving care from a child just because a parent or guardian isn't immediately available to provide consent. Okay, so if the emergency is like real, consent is going to be implied, just like it would be for an unconscious adult. So an example, you respond to, let's say, a playground, right, where a 10-year-old suffered an allergic reaction, like a severe allergic reaction. They're going into anaphylaxis. The school staff can't be reached, or not the school staff can't be, they can't reach the parents, right? You don't wait, okay? You don't have to wait and keep calling that parent. You're just going to treat the child under implied consent. You're going to administer epinephrine. You're going to manage their airway and their breathing, and you're going to transport to the most appropriate receiving facility. With that being said, again, your documentation must be thorough. Okay, clearly describe why consent cannot be obtained, why the situation was emergent, and what efforts were made to contact that parent or legal guardian. Also, really just follow local protocols regarding whether a school official or whomever must accompany the child to the hospital in place of the parent. So make sure someone goes with you in the ambulance. And depending on your ambulance company, they might be in the back of the ambulance with you, or they might ride up front. But just remember, when the child arrives, at the hospital, further care may be delayed until that consent is delayed. So if that child needs surgery, they might kind of hold off to the last possible second until they can get that parent or legal guardian to consent. But again, that's why contacting a legal guardian as early as possible is really in everyone's best interest, not just legally aspect, but for the medical aspect as well. Forcible restraint. Okay, so this is a serious action that sometimes is necessary for safety. Okay, but it always must be legally justified. Okay, so forcible restraint may be needed when a patient is combative. They pose a danger to themselves, a danger to you, the paramedics, the firefighters, or just to any bystanders in the area. Um, Typically, they could have a serious medical or behavioral condition, but is actively refusing or trying to leave. Okay. These situations are often volatile and really high stakes, honestly. If you need to ensure that you need to ensure that you, your partner, and the patients are safe. Okay. Most states do require that you contact medical control or law enforcement before physically restraining a patient. Typically speaking, in California, you have to have law enforcement put the patient on a hold prior to restraining. Otherwise, you could potentially face assault, battery, and false imprisonment charges. Um, some states do require that only the police officers are able to apply physical restraints. So that's why it's really important for you to be familiar with your local laws and really your agency's protocols. Now, once the patient is restrained, you take on a greater level of responsibility. So, some critical points: you never want to remove the restraints during transport. Okay, even if the patient says, "Hey, they'll behave," they're sorry, they're not gonna make a big deal out of this. Unless they're like physically harming themselves, or their vitals are like at risk and they're like starting to circle the drain, that would be one reason you would think about it. But for the most part, even if they're physically harming themselves by like just being so violent and trying to escape, the biggest issue you might run into is that you let them go or they escape, and then now they're jumping out of a moving ambulance onto the freeway. So that's a big safety risk for the patient and also for you. You always want to, when a person is restrained, monitor their airway, their breathing, their circulation constantly. Improper restraints can lead to complications like asphyxia, aspiration, and cardiac compromise, right? So back in the day, they used to restrain patients on a backboard and flip the backboard upside down. So the patient would be sandwiched between a backboard and the gurney, and now the patient wasn't able to like really fully expand their chest, and they would actually suffocate. So we've gone a long way from that, and we'll cover that when we get to behavioral crisis on how to actually properly restrain a patient. Um, when you're also restraining a patient, make sure you're protecting the patient's dignity, right? Don't restrain someone in any type of demeaning or unsafe position. Always use your. It's okay. Don't restrain someone in a demeaning or unsafe position. Always use protocols approved by really your medical director and your agency. Okay. So you should also document everything in detail, right? So the reason the restraint was necessary, what was the patient's behavior, what method of restraint was used, who ordered or authorized it. And then again, all vitals and reassessments throughout transport. Okay. If you believe a pharmacologic or a chemical restraint may be safer than physical, that's when the advanced life support, your paramedics, could actually be of use there. Okay. So the medications can often calm a patient without the risk of the physical struggle aspect. Lastly, remember that this restraint is a medical intervention. Okay, so use it only when justified, apply it safely, and then document again thoroughly at the end of the call. Uh, so, as EMTs, one of the most challenging situations we may face is when a patient refuses treatment or transport. Okay. Even when it's clear that they need help. Uh, but here's the legal and ethical truth. A conscious, alert adults with decision-making capacity, they have the right to refuse treatment at any time, even if that decision may lead to serious injury or death. That is the right of this patient, and it's grounded in what we call, again, autonomy. The principle that people have control over their bodies and their medical decisions. That means even if someone is having chest pain or showing signs of a stroke, if they understand the risks and refuse care, you have to respect that decision. But again, it's your job to make sure you inform them of the risk and inform them of what the outcomes could be if they do refuse care. So these cases are legally risky. Okay, so there are many lawsuits in EMS that begin with the refusal calls. So you must take these situations very seriously, follow your protocol, involve medical control early on in the process, and really just document your interaction in full detail. Okay, so what you said, what they understood, and really why they refused. Um, so continuing on that, so we have to assess, we need to talk about assessing a patient's ability to make an informed refusal. Okay. So before you can accept their refusal, you need to ensure that they have decision-making capacity. That means they understand what's happening, right? They comprehend the risk of refusing treatment, and they communicate a rational choice, right? To assess this, you need to ask the questions and evaluate how they respond. Are they oriented to person, place, time, and event and reason? Are they under the influence of drugs, any alcohol? Do they have a head injury? Do they seem confused? Are they emotionally unstable, mentally altered? Really, if the answer to any of those questions is yes, then you cannot assume the refusal is informed. And then implied consent may apply. Okay, so in particular, anyone expressing suicidal intention, right, or recently attempting self-harm should never be regarded as having normal capacity. So you must treat and transport these patients, and unfortunately, it's going to be typically with law enforcement support because most of the time they're not going to want to go to the hospital. But again, when in doubt, you should always treat, right? It's legally and ethically more defensible to treat a confused patient than to walk away from one who actually needed care. So even when you've confirmed that the patient has capacity and they're refusing care, there are a few key things you must do. Okay, so explain clearly. So tell them what you believe is wrong, what treatment you recommend, and what may happen if they don't receive care. Okay, I definitely always want to encourage questions, so make sure they understand your explanation. Involve medical control when necessary. Involve the paramedics. Let the physician, so that's going to be your medical director, or the whoever is the base of the medical control at the time, let them speak with the patient directly if it's necessary. But by all means, you need to document everything, including all the attempts you made to obtain consent. If you're unsure whether the patient is competent or you're just uncomfortable leaving the scene, just get law enforcement involved. Their presence can actually help manage the situation a little bit, especially if the patient's condition deteriorates after you leave. And remember, your safety should always come first, right? So if you're threatened, just step back, wait for assistance, and really don't place yourself in harm's way, just trying to force care. Um, Now, the final steps before leaving a scene of a refusal, like before you actually walk away, you need to try at least 3 times to convince the patient to accept care. Okay. Explain the consequences. This could be life-threatening. We strongly recommend you going to the hospital. Something simple as that. Really, and also advise them to call 911 again. So if all of a sudden they're feeling worse, they're allowed to call 911 again, and you'll go right back out there and treat and transport. And also encourage them to go see a physician like immediately if their symptoms worsen, and that's if they're refusing care. And then have them sign the against medical advice form. That's going to be your refusal form. And make sure it's witnessed by a family member, bystander, or a police officer. This is really where you don't want to have just your partner be the one who's going to be the witness, because in the court of law, it's going to be easy to fight that as a lawyer. Like, oh, of course your partner is your witness. They have to be. So you want to get someone outside of your agency. So having a family member is one of the best ways. But if they're not there, then get another public servant like a firefighter or a law enforcement officer. Bystanders you could use as well, but again, that's not what I would necessarily want to go with. I would usually go with law enforcement or fire. Um, yeah, and then if they refuse to sign, document the refusal and inform medical control. Okay, because they don't legally have to sign that AMA form, but just make sure to document that they just straight up refuse to sign it. Um, because remember, a signed refusal form doesn't really guarantee legal protection for for yourself, but it does help demonstrate that you did your due diligence, right? Your PCR should include your assessment, their stated reason for refusal, your medical explanation, all refusals, witnesses' names, and your contact with medical control. So again, it's just another situation where documentation is going to be the best thing to protect you legally and professionally. If a parent, however, refuses care for their child, the situation becomes a little more sensitive. Again, use calm, respectful persuasion, and if needed, call for a supervisor or law enforcement. If the refusal puts the child at risk, the parent may be investigated later on for neglect, and you might have to get CPS involved. Um, confidence. So if as we shift to confidentiality, which is another cornerstone of medical ethics and EMS law, as EMTs, everything we see, everything we hear and do with a patient is considered protected. Okay, that includes medical history, assessment findings, the treatment that you provided, really anything said during that call. The information is confidential and can't be shared with anybody without proper authorization. That means you can't talk about it to your patient with friends. As in, you can't talk about your patient with friends. You can't post it on social medias. You really can't even discuss the call casually at the station. Breaching confidentiality is it's not just unethical, but it could result in legal action and a loss of your EMT certification. The only times you can legally share patient information is if the patient themselves sign a release form, if it's like a court subpoena, or when sharing information with other medical personnel directly involved with the patient care. So that's when you're doing the handoff to the nurses. You're allowed to actually give information about that patient. Another common one as an EMT working in the private sector is going to be for billing purposes. So this is going to be allowed under privacy laws, but yeah, you can talk to your billers, your insurance individuals, because they need to know what was conducted for that treatment was conducted because they need to know what to charge. Um, so your role as an EMT really demands discretion. So what a patient tells you in the back of an ambulance is really not public information, and should really never become gossip. Okay. Now, in to circle back in our classroom setting, we do talk about the patients you see during your ride-alongs and internships, but we make sure that you're not giving any personal information about the patient. So you're not telling us their names, you're not telling us your social security numbers, their addresses, nothing that could really be identifiers. But we do want to use it as a teachable learning moment to have you guys debrief and express like what you saw, what you did during your internship experience. Um, Perfect. So now as you know, I digress. Now let's go into one of the more important things is going to be HIPAA. Okay. So this is the Health Insurance Portability and Accountability Act. Okay. also known as HIPAA. This was passed back in 1996. It's really it really fundamentally shaped how we handle what we call protected health information, or PHI. This law requires that all healthcare providers, including EMTs, to safeguard patient privacy and limit how medical information is used or disclosed. This protected health information includes any information related to the patient's health, their care or treatment, the payments, really anything that can identify them. That means, names, addresses, medical histories, vital signs, social security numbers, like I said, even photos, right? HIPAA has pretty much three core rules that we follow in EMS. Number one is the privacy rule. Okay, so this is going to protect the use and disclosure of this health information. We have the security rule. Okay, this is going to require safeguards for the electronic protected health information, and then the minimum necessary rule. Okay, so this means you may only share the smallest amount of info needed to do your job. Okay, any violation of these rules, even if they're unintentional ones, can result in a civil or criminal penalties. And don't assume this only applies to hospitals. Like, you as an EMT are held to that same high standard. These HIPAA violations, they can happen like pretty easily and often without any type of like malicious intent. But even small lapses can have like really major consequences. So let's give over a couple common examples, right? Of HIPAA breaches in EMS. Um, a very common one, leaving a patient care report unattended on the gurney or in public review. A little bit more of an issue back in the day when we had the handwritten patient care reports. Electronic care reports, not too big of an issue nowadays. But another issue, talking about a patient loudly in the ER hallway, right? Because you're going to have a bunch of medical providers, but also patients and family members just all around. Another big topic and issue is taking photos or videos of a scene or patient. Even if they're not shared, you're not supposed to take pictures of the patient or the actual scene. Um, Texting your partner about, that crazy call we just had. Again, you're not supposed to talk about these situations outside of the medical concepts, but there are some exceptions, like for educational purposes. But all of those might seem relatively harmless, but each of them, again, is technically a breach of confidentiality. Um, Now, let's talk about or address something that confuses a lot of EMTs, and that can members of the public record use while we're working? So can members of the public record use while we're working? And yes, if you're providing care in public, sorry. Or meant record, right? So can members of the public record us while we're working? Okay. And the answer is yes. If you're providing care in public, say like on a street corner or, some type of venue, the general public can legally record you, but you cannot record them. Even with good intentions, like you also cannot order a bystander to stop filming unless they're directly interfering with patient care or scene safety. So what should you do? Really just ask respectfully, would you mind not recording us to help protect the patient's privacy? Often that's all that it takes, but if it doesn't and the bystander refuses, you're just gonna have to like move on and pretend like they're not even there. In some extreme cases, you can get the law enforcement involved to kind of help secure the scene for you. Um, so social media, that's another big, getting more and more common is just HIPAA violations through social media. So you can't post pictures of patients, right? You can't describe your call in enough detail that someone could actually identify the patient. Um, Can't use references or hashtags to locations, injuries, or any agency that might reveal who was treated, right? If the patient isn't named, if someone could figure out their identity based on your post, that's what the violation is. So really be mindful of your off-duty behavior as well. If you're wearing your uniform, displaying your agency logo, posting from the station, your free speech may not be protected in the way it is for the general public. Okay. So here are a few like best practices to follow. Never share the PHI in person or online. Avoid any identifying markers, location, agency, diagnosis, and really just think before you post. Like, would I be okay explaining this in court, right? So really, in just short, your professionalism online must match your professionalism on scene. Advanced directives. So advanced directives are legal documents that communicate a patient's wishes for medical care. In cases they become unable to make their decisions later on. One of the most common types of advanced directive is the DNR, or the Do Not Resuscitate Order. This tells EMS providers and hospital staff not to initiate CPR if the patient is in cardiac arrest. But it's important to remember DNR does not necessarily mean do not treat. Okay. If the patient is having difficulty breathing or needs comfort care, you're still expected to provide interventions like, oxygen, pain relief, just emotional support, as long as they are not considered resuscitative. Okay. So, how do you recognize what a valid DNR looks like? So, it really must state the medical condition it applies to. Okay, an individual with advanced directives or DNRs, they're typically on end of life care. They're on hospice care. So they have some type of terminal illness, right? You can't just have a DNR and be a perfectly healthy individual. It also needs to be signed by the patient or the legal guardian or the what's the name of it? Not an advocate, but they're a power of attorney, so to speak. But it also must be signed by a physician, and in some states, it actually must be dated within 12 months. Okay. If you ever encounter a DNR and you're just unsure whether it's valid, you start your care, but then contact medical control and see how they want you to proceed. DNRs, the Do Not Resuscitate Orders, they're really only one form of what we call an advanced directive. Okay, there are others such as living wills, which is kind of outlines the type of life-sustaining treatment the patient wants or doesn't want. There's healthcare directives, which is just like another term for advanced directives, just used more broadly. Then there are like things like physician orders for life-sustaining treatment, or POLST. And then there's also medical orders for life-sustaining treatment. These are medical documents signed by a physician, a nurse practitioner, a physician assistant that really explicitly describe which treatments should or shouldn't be used. But unlike DNRs, these POLST or MOLST rather, the POLST or the MOLST forms often contain a full set of instructions. Like, for example, use oxygen and IV fluids, but don't intubate, or comfort care only, no CPR. As an EMT, it's your job it's not really it's not really your job is not to interpret these forms, but it's just to recognize them and consult medical control if there's any uncertainty. But really don't delay care while you read through the complex, documentation. Treat based on the patient presentation and get guidance as quickly as possible. Um, So let's take a look at some advanced directive forms and like what they actually look like. They vary from state to state and like kind of area and area. But typically on like this slide, you'll see an example of what we call a wallet-sized or pocket-sized DNR. Patient or family members may present one of these at the scene. Sometimes it's actually printed on brightly colored paper like pink or yellow to stand out during an emergency. Um, when you're presented with a DNR, again, check the signatures. Is it signed by both the patient and the physician? Check the expiration date. Is it, because again, in some states, it has to be within 12 months. And most importantly, check the situation. Like if the patient is not in cardiac arrest, you should still provide supportive care. And really always remember if you cannot confirm the document is valid, err on the side of caution, err on the side of initiating care, and then consult online medical control immediately following that action just for direction. Because if you mistakenly withhold care and the document turns out to be invalid, your actions could actually lead to legal consequences or even disciplinary actions. So again, let's look at the POLST and MOLST again. Again, these aren't just like preferences; they're physician signed orders. Okay, that and they carry a lot of legal weight. So these documents explicitly list what life-sustaining treatments are acceptable to the patient. They're really often used in like hospice and palliative care. Again, that's that end of life care. And it could include like a do not resuscitate, allow for natural death, use antibiotics for comfort only, no artificial hydration, just random things like that, right? So as an EMT, your job is again just to recognize these documents. You're going to treat the patient according to what's allowed, and again, consult a medical control immediately if there's any doubt. Keep in mind that some of these orders are specific to location, so they may not be valid if the patient has traveled across state lines, right? But again, it's not your job or your role to question the patient's choices. Your role is just simply to honor them within the legal and medical boundaries of your scope. So some patients may have designated someone to make the decisions for them. Okay, person is usually called a healthcare proxy, also known as having some type of durable power of attorney for healthcare. Okay, this means that if a patient becomes unconscious, unable to make decisions, the healthcare proxy will step in and legally speak on their behalf. But the key rule here is that this only activates when that patient loses capacity. Okay. So if the patient is awake and alert, they're still the ones in charge, even if their family healthcare proxy says otherwise. So these documents can really vary widely, and not all powers of attorney allow for medical decisions. So if someone presents you with paperwork claiming to be a proxy, again, just read it carefully. And as always, like when in doubt, just call medical control. Um, Also, remember, none of these documents mean do not treat. Okay. So, again, even with the DNR, you're still responsible for comfort care, oxygen, airway maintenance, pain management, emotional support. And then finally, never show frustrations if a family calls 911, even if a DNR is present, right? They may just be confused, overwhelmed, or just scared. Respect their emotions and again, handle the scene with compassion and professionalism. So now let's turn our attention to the topic of death. Okay, and this is how EMTs recognize when resuscitation is inappropriate. Okay, in the field, it is not your job to declare death. Okay, that's really the physician's responsibility. But you may encounter cases where resuscitation is just clearly, it's not worth doing. Okay. And in those cases, you must recognize what we call signs of death to really guide your decisions. Okay. There are two categories. We have something called presumptive signs. This is going to suggest death, but are not absolute. But then we have definitive signs, okay? And these are going to be like obvious, which are conclusive, right? Conclusive presumptive signs, or just conclusive, sorry. Presumptive signs of death include no response to painful stimuli, no carotid pulses, no chest rise and fall, no deep tendon or eye reflexes, profound cyanosis. The pupils are fixed, non-reactive, no systolic blood pressure, and a decrease or cold body temperature. Okay, those are just presumptive. Okay. In some states, or in most states rather, multiple presumptive signs are needed to withhold care, especially if the patient has not been under any physician supervision or is just like found unexpectedly. Okay. But now let's look at the definitive signs of death. Okay. These are like the clear, unmistakable signs that resuscitation efforts should not be initiated. Okay. Even in the absence of a DNR. This includes obvious mortal damage. Okay. This is like decapitation or incineration. So, decapitation means the head of the patient has been removed from said body. Incineration means that the body has been burned to essentially a crisp. Dependent lividity, okay? This is when you have a pooling of the blood to the lowest parts of the body or the most gravity dependent body part of the body. And this is caused when a person, essentially dies, all the blood vessels dilate and that blood is going to start to pool, okay? And that's going to create like a purplish discoloration. Usually you'll see it on the patient's back, or their sides when a patient is lying. So it's really however you find them. If you look on the most gravity dependent position, that's where you're going to first see that purple coloring. Another one is rigor mortis. Okay, so this is when you actually have a stiffening of the muscles after death. Okay, so it typically begins in the jaw and the face, and it's going to progress downward. Usually sets in about 2 to 12 hours after death. It really depends on the environment. So one of the first things you might do when you're responding to a call of a patient. Especially if all the signs are pointing to kind of like a death, you're going to kind of open up the jaw, like move the jaw and see if it actually moves at all. And if it doesn't, it's just like locked in a position. That's a good sign that it is rigor mortis. Another one is going to be algor mortis. This is like the overall cooling of the body until it reaches what we call an ambient temperature. You have putrefaction. Another word is just for decomposition. So that's when the body actually starts to deteriorate, and that's going to happen between like 40 and like 96 hours. In any case where these signs are present and no like DNR or physician order exists, you're still expected to not initiate CPR because they're obvious signs of death. Okay. However, and again, this is really important. If you're ever unsure, start care, contact medical control, and never assume death unless the signs are clear and again, your local protocol allows it. So here on the slide, we have a nice dependent lividity on the patient's back. So again, this is a definitive sign of death that you may encounter in the field, okay? Dependent lividity is also called livor mortis. It's really the discoloration of the skin that occurs, again, when the body settles to the lowest part, the blood of the body settles to the lowest part of the body after the heart stops circulating it. Okay, this pooling typically appears as a purple, a bluish hue on the back, the buttocks, or the sides. Really, just depends on the patient on how they're positioned. So why does this actually matter to EMS? It's really because lividity is one of the clearest field indicators that resuscitation would be inappropriate, right? It tells us that the patient has been deceased for quite some time, and really it's going to be too long for CPR to have any meaningful effect. But remember, when you see lividity, it must be accompanied by a complete absence of signs of life, right? In many jurisdictions, approval from medical control and or following local death determination protocols is still required before terminating all efforts or from initiating them at all. And it's important to keep in mind hypothermia, which is just like a drop in the body's core temperature, it really can complicate the death assessment. A hypothermic patient can appear to be deceased, but still might be salvageable. Okay. So the rule and the saying that you're going to hear quite often is they're not dead until they're warm and dead. So if you're ever uncertain whether the signs like cyanosis or lack of movement are due to cold exposure, just again begin care and just call medical control and let them guide you. So continuing on with we have rigor mortis again, algor mortis, and putrefaction. Okay, so again, all of it, which like I talked about, are definitive signs or obvious signs of death. Rigor mortis again refers to the stiffening of the muscles due to chemical changes after death. It happens about 2 to 4 hours after post-mortem, starting with the face and the jaw, progressing downwards. If you ever encounter a body that is fully stiff, with the limbs, like the arms and legs, are locked into place, again, that's a strong indicator that resuscitation is just not appropriate. Okay. Algor mortis is the again natural cooling of the body until it reaches the temperature of the surrounding environment. So it's really a useful clue, but algor mortis alone really isn't enough, at least sufficient enough evidence to declare death, because it's so gradual and influenced by factors like the room temperature, clothing, and that's the overall body mass of the patient. So you want to have a little bit more before calling the patient at that point. Putrefaction is really the decomposition of the body tissue, so decomposing body. It's really the final and most obvious signs of death because it includes bloating, a real foul odor, invisible skin discoloration, or breakdown. Again, this typically is going to be between like 40 and 96 hours after death, and it's widely dependent on the environmental conditions. If you ever encounter these signs, though, there's really no need to initiate CPR. But again, documentation is going to be something you have to do and take a lot of effort into. But really just follow your agency's protocol and ensure the scene is preserved, especially if the death appears suspicious and may involve some type of criminal activity. So when a death occurs, we need to get a medical examiner involved. Okay. In most states, certain types of death must be reported to a coroner or the medical examiner, even if EMS wasn't the primary care provider. So these situations usually involve trauma, violence, any unusual kind of circumstance where like it could be like a criminal situation. Um, so here are some examples. A DOA, right? So someone who's dead on arrival or dead on scene patients. Deaths without recent or ongoing medical care. Suicides or suspected suicides. Violent deaths such as stabbings, shootings, suspected poisonings or drug overdose. Accidental deaths like drownings, falls, fires, deaths involving any type of suspicion of criminal act, really any infant or child death, those are always going to be considered high priority for investigations. And then when these situations arrive, it's really your responsibility as an EMT just to notify dispatch immediately so law enforcement and the coroner can be activated. You don't need to investigate or even speculate. Your job is simply to preserve the scene, protect yourself, and then treat any surviving victims. Once you've identified the possible medical examiner case, though, your next role should be to limit any disturbance of the scene. Okay, so this is really important because when a death is suspicious, the position of the body, the presence of blood or weapons, even footprints or drag marks can provide like vital forensic evidence. So, really, any unnecessary movement by EMS personnel could compromise a criminal investigation. So, some best practices for these situations: don't cut through bullet holes or stab wounds when you're going through the clothing. Avoid walking through the blood or any bodily fluid on the ground. And if you do, just make sure to document it very thoroughly. Don't remove any evidence like weapons, clothing, or prescription bottles, really, unless it's necessary for safety and resuscitation. Avoid disturbing anything unless you must provide like life-saving care. If the emergency care has already been initiated, you really just need to document everything, include the actions taken, the patient's initial condition, and really any changes at all. Even the absence of treatment must be documented clearly, along with the rationale, such as, like again, the presence of these definitive signs like lividity, rigor, or maybe a valid DNR. And once the medical examiner takes control of the scene, their authority supersedes yours. Okay, so and that's including that of like law enforcement or hospital staff, like staff. They're the ones who are going to be in charge. So let's kind of shift gears a little bit. We can talk about special situations. Starting with organ donation, right? Some patients may be registered organ donors, right? Which you can often confirm by checking their driver's license or a donor card that they carry. In rare cases, the family may also notify you directly. If you encounter a patient who has expressed a wish to donate their organs, your priority is still the same, and that's to save the patient's life. Organ preservation really depends on the tissue oxygenation. So even if the patient is unlikely to survive your care, especially airway survive like your care, especially like airway management, oxygenation, circulation support, that is critical to maintaining viable organs. Okay, so this becomes even more important near hospitals that are affiliated with organ procurement organizations. But in some cases, like the kidneys, livers, or other organs may still be harvested from a patient who was not resuscitated. But it's really only if proper care was provided up until that specific point. But again, it's very important. Organ donation is voluntary. So even if you're uncertain about a donor status or whether to initiate or continue care, just call medical control for direction. But again, your job is to treat the patient and not really worry about whether or not the patient's an organ donor. Your job should be to attempt to save a life. So on this slide, here's an example of a this is an organ donor card. I don't know where I don't have my wallet with me. Actually, do I? Actually, I do. Let me pull out my without kind of giving too much of my information away. So here, I don't know if you guys can see a little sticker right there. So that's an organ. So that right there is an example of a driver's license marked with organ donation, right? It's going to be one of the most common form of documentations that EMTs will encounter in the field. So if you see Sorry, I clicked the button. No, we're good. So if you actually see the little circle where it says donor on a license, just note it in your documentation, right? You're not responsible for initiating the donation process, but your role, again, is to preserve life until care is transferred. Includes supporting perfusion, maintaining viability of the transplantable organs. It's important to treat every potential donor with the same clinical urgency as any other patient. So don't let the assumption about their prognosis, their survivability really affect the care you provide. Because again, donation can only happen if the organ remains viable. And that depends on the again the oxygenation, the circulation, and the transport to the hospital. In some cases, your protocol may include notifying the receiving hospital that the patient is a registered donor. But again, just contact medical control before you initiate that treatment plan. And then again, right here, I think I just talked about it, is the organ or tissue donation card that you might also find in the wallet. Next one. There we go. Uh, Next up, so medical identification insignias. Okay, so some patients are going to wear medical alert bracelets, necklaces, keychains that are going to provide critical health information. You might also find a wallet card or in more modern cases, a USB flash drive. I've never seen one of those in the field yet, but they are out there. But that kind of thing will contain like medical history, allergies, emergency contacts. Honestly, nowadays more so it's on the cell phone. There's like a little emergency contact on like the home screen, and that could actually open up a lot of pertinent information about the patient's health without having to use their passcode to get into their phone. But you should again always check the patient's neck, their wrist, and their wallet for this kind of medical alert tag or identification. It's really important to check this for patients who are, unconscious, they're unresponsive, found alone with no bystanders. If they're known to have like diabetes, seizure disorders, allergies, cardiac disorders. If you ever encounter one that actually says DNR, honestly, that's not enough on its own. A formal DNR form needs to be signed by a physician. Okay, so that's what's still legally required to withhold resuscitation. So it's gonna be kind of rare to have a DNR bracelet or medical alert tag, but they can still have it. But you still need that form to withhold resuscitation. But yeah. So also document what you find when you're doing your patient care report in your narrative. Include, the description of the medical alert tags, the USB device if you found one. Even if it didn't really change how you treated the patient, just still document that you found it. Because again, this kind of documentation shows that you really performed a thorough assessment and you did your best to protect the patient and try to best treat them. So here you can see an example of a medical ID bracelet on this pediatric patient. One of the most like trusted organizations in this game is called Medical Alert. They offer 24/7 phone access to a patient's full medical profile. So on that actual medical alert tag, you'll have the phone number. Okay. And it's also going to have like an ID number because again, you're not going to necessarily know the patient's name and information. So having that identification number plus the phone number, you can get a lot of good information from that provider. And in many cases, especially when patients are unresponsive, like these bracelets, these cards are the only clue you might have to an underlying condition. Like, patient might have a bleeding disorder like hemophilia. They might have severe allergies to certain medications. They may have seizures. Maybe they have like an implanted pacemaker or defibrillator. Maybe they, again, have a DNR order. But again, it doesn't mean like you're going to withhold resuscitation, but it's going to make you question the situation and try to find that DNR form. So really keep in mind that Also, some of the newer bracelets are like QR codes now. Again, technology is awesome. So train yourself and your crew when you actually get hired to look for these tech kind of based identifiers, as well as the traditional tags. Because again, these tools may not replace formal documentation, but they really can guide the early care decisions that provide clues in really these confusing and high stress situations. Um, Shifting again, let's go over your scope of practice as an EMT. So the procedures and interventions, the procedures and interventions that you're legally authorized to perform as an EMT. Okay, so your scope of practice is really defined by state law, your EMS systems, medical director, and the training you've completed and your current certification level. Your medical director adds detail to your scope by creating protocols, the standing orders, which really are the roadmap for patient care. So these can be like online, meaning you get direct orders over the radio or the phone, or they can just be offline, like your protocols that you're just going to follow out automatically in the field. You're really legally allowed to perform only what falls within this defined scope of practice. If you exceed it, for example, by administering a medication not approved for EMTs, or just simply performing a skill that you weren't specifically trained for in your program, that's called practicing medicine without a license, and it may carry a criminal or civil penalty. If a situation arises where a higher level skill is needed, the correct course of action for you is to call ALS, right? And provide supportive care until they arrive, not to simply improvise and guess, right? Even if you were like, trained on a certain task, just because you kind of messed around and learned how to do something, if you're not medically certified to do a skill, it's not in your scope of practice, you shouldn't do it, and you can't do it. Um, it's critical to understand that your scope of practice is not the same as your standard of care. Okay, though they often get kind of confused with one another. Your scope of practice is simply what you are legally permitted to do. Your standard of care, however, is how you are expected to perform those tasks, like the level of quality, the competence, and the competence that your agency and the courts really expect from you. Okay. For example, like you are within the scope to administer epinephrine using what we call an auto injector. Okay, but if you administer it incorrectly, say let's say you injected it into a vein, right, instead of a muscle, you may have followed your scope, but you violated the standard of care. Okay, and also remember your scope can change over time. New protocols may be added, medications may be removed, may be added based on new evidence and research. So it's kind of up to you, and it's your responsibility to stay up to date and follow your agency's policies and really just seek clarification when it's needed. And I've been saying this a lot, especially for this chapter because it's so true. When you're in doubt, just consult medical director, a supervisor, get online medical control. Because again, it's better to ask a question than to commit an action that results in harm, liability, or potentially your license being suspended or revoked. So again, to continue on with standard care, again, this is how you're expected to act as a professional EMT. Okay. As a healthcare provider, you have a legal and ethical responsibility to ensure the safety and welfare of your patients. Okay. Your standard of care is determined by how a reasonably like prudent EMT with similar training would perform under similar circumstances and conditions. So, in other words, it's not really about being perfect, right? It's about having a reasonable competence. Okay, could another EMT in your situation with your training, your experience, have done the same thing? If the answer to that is yes, then you likely met the standard of care. So it really means that following protocols, acting within your scope, using equipment properly, and adapting to the scene conditions, where that's where these standards are especially important in these emergencies, because the conditions may be chaotic. Okay, so your behavior really must still reflect concern for patient safety and the adherence to best practices. Uh, so where exactly do these standards of care come from? So they've been established by local customs. So that's really what routinely is done in your EMS region, right? It's established by state and federal law. You have your protocols, your standing orders from your medical director, the textbook, including the one like we're reading right now. Professional organizations like American Heart Association, the National Highway Traffic Safety Administration. An example, like for AHA CPR guidelines, these are national. This is a national standard. If you deviate from those guidelines without a valid reason, you might be held liable for negligence or malpractice. So it's also important to note that emergency conditions may alter expectations. The courts recognize that the chaos of an emergency scene it may affect how care is being delivered. But regardless, you're still expected to perform assessments as completely as possible, to act with the patient safety in mind, to communicate and to document. Okay, so those are all still expectations regardless of the situation. Um, and then, so there's a couple extra layers to this. Some states have enabled what's called the Medical Practices Act. This defines and limits the scope of all healthcare providers. So while EMTs are often exempt from like physician licensure, your authority to provide care still derives from these specific laws. You also have standards imposed by certification and licensure boards, court decisions, case law, which can like influence future expectations later on, institutional policies within your specific agent or agency or EMS system. So the key here is that you really need to know your protocols, follow your medical director's expectations, and but above all else, stay current with your state and national updates. Another thing that is thing to understand is that your textbook, the Emergency Care and Transport of the Sick and Injured 12th edition, it's often considered a recognized legal reference in court. So if a question arises about whether you followed proper standard, a lawyer may literally open up this textbook and did you do what's written here, right? Or did you deviate and do what's they do in the field versus what's in the textbook? So really mastering the material in the textbook in the classroom is not just about passing your exams. It's really about knowing what you're responsible for when you're out on the streets, when you're in the rig, and inevitably potentially on the witness stand. Um, Again, let's keep it going. Let's talk about the duty to act. Okay, so a term that defines when you are legally required to provide care. As an EMT, like when you're working in the capacity, you have a duty to act when you're on duty with an agency and dispatched to an actual call. You have a duty to act when you begun treatment, regardless if transport occurs. You have a duty to act. Your agency's policy requires you to assist. Okay, so that is like the duty to act. So you're on duty, you're getting paid for the actual job. That means that's your duty to act. Now, if you're off duty, you may have a moral obligation to help, but it's not a legal obligation. The only time it actually becomes a legal obligation for you is if you actually started care, right? So you can't all of a sudden be off duty, start treating somebody using your own like medical training and expertise, and then leave without transferring care. Because again, like once you start providing care, it's your responsibility to continue. Now you can stop. Like you can pretty much continue until you transfer care to an equal or higher level provider. As an EMT, this would be like more like another EMT, a paramedic, or a nurse. If the patient refuses treatment, or if you become physically unable to continue, okay? So failing to act when you have a legal duty can be considered negligence, and may open you up and your agency to legal consequences. But again, there's got to be a couple extra little elements to prove, and we're going to talk about that. So the concept of negligence, right? It's really important to understand this is a serious and concept in EMS. Okay, negligence means simply failing to provide the same standard of care that another EMT would do with similar training. Okay, it's not about making a mistake, right? It's about failing to act reasonably and then causing harm because of it. Okay, in reality, there are four elements that must be proven in a negligence type case. Okay, the first one we already talked about. It's a duty to act. You had a legal obligation to care for a patient. Number two, you have what's called a breach of that duty. That means you did something wrong or failed to do something you should have. Number three, damages. The patient suffered harm, whether that was physical, emotional, financial. And then lastly, there has to be causation. That means your actions or failure to act directly cause the patient's harm or damages. So all four really must be present for negligence to be established, okay? So if one is missing, for example, if no actual harm occurred, then negligence cannot be legally proven, okay? But you protect yourself from negligence by staying within your scope, by following your protocols, documenting carefully, and really delivering care that is competent, compassionate, and inevitably by the book. So again, we kind of already hit on this. Again, negligence, duty. So I want to kind of hit on a little bit deeper, right? So duty. So this is the foundation, right? Your responsibility is to provide care because you were dispatched. You were on duty and you already began care. Without a duty to act, negligence simply cannot occur. You have a breach of duty. This happens when your care fails to meet that standard that it was expected. Someone with your level of training. It could be an action like you administered the wrong medication or an omission like forgetting to apply oxygen when it was clearly needed. For the damages, there has to be some type of provable harm, right? So physical, emotional, possibly financially. But for example, like a missed internal bleed that leads to a patient's deterioration may constitute as damages. Okay, and then lastly, causation. That's the breach must be the direct cause of the damages. Right. So your breach of duty caused the damages specifically. So yeah. So in other words, the harm wouldn't have occurred if not for your specific breach. With all four, the duty, the breach, the damages, the causation, a negligence claim won't stand in court. So, but if all four are proven, you, your partner, your agency, and possibly your medical director could be held liable. Um, Now, there are two types of legal doctrines that's specifically related to negligence for EMTs that you should be aware of. Res ispa equitor, which means that the thing speaks for itself. This legal theory really applies when a patient is harmed under your care in a way that clearly wouldn't happen without negligence. And the patient is unable to explain how it occurred. Okay. For example, let's say you had an unconscious diabetic patient and is dropped during a stretcher transfer. Okay, and sustained facial lacerations. The patient can't explain what happened because they were unconscious, but it's evident they were injured while they were in your care. Okay, that alone might be enough to establish liability. Another one is negligence per se. This is when an EMT violates a law or protocol just outright. Such as, like, let's say if you perform an ALS procedure, like you did an IV medication administration when you're only a certified EMT and the patient is harmed, it's automatically considered negligence because the act violated your legal scope of practice. Um, both doctrines really emphasize the importance of knowing your role, right? Staying within your scope and delivering care that is consistent with standards and protocols. So even when the patient can't speak for themselves, the evidence of what occurred under your care can speak volumes. Okay. Abandonment. Okay. So this is another serious legal violation, and one that is kind of misunderstood. So abandonment can occur when an EMT unilaterally terminates care without the patient's consent and without making appropriate arrangements for what we call continuity of care. And this continuity of care has to be by an equal or higher level medical provider. A classic example is, let's say you start care on a trauma patient, but then leave the scene to respond to another call. Handing the patient off to a bystander or firefighter who isn't medically trained, that would be considered abandonment. Okay. Another common one is abandonment can happen when you're actually at the hospital. So if you arrive at the hospital and you just drop off a patient and fail to give a verbal or a written report to a nurse or some type of provider, and something happens to that patient, you could be held accountable. Okay. So to simply avoid this, it's kind of easy. Just never stop care mid transport. Again, the only time you ever would is if your safety is at risk. Always ensure transferring of care is made by someone who is licensed and capable. And then again, document the name, the time, and the title of who you transferred the patient care to. And that all goes into your actual patient care report. Um, I hit on this earlier, but let's clarify really the difference between assaults and battery. Okay, because both can occur, unfortunately, unintentionally in EMS. Assault specifically is when you place a patient in fear of harmful or offensive contact. Okay, you haven't touched them yet, but they perceived a real threat. For example, like if you don't cooperate, I'm going to strap you down. So you're threatening to restrain a patient for not cooperating. That would be considered assault. Okay. Battery, on the other hand, is the unlawfully touching of a person. So it doesn't have to be necessarily violent. Even routine care without proper consent, like inserting an airway, splinting a limb without permission, can be considered a battery. Both actions can be either civil or criminal, and the intent isn't always required. Even if you meant well providing treatment to a competent patient without consent, this can result in liability. So remember, consent is what's there to protect you. So without it, you could be committing a crime, even if the treatment was appropriate in the situation. Um, let's keep it going. So what can also happen with assault battery could be kidnapping and or false imprisonment. Okay, so kidnapping, yeah. So in theory, this could happen if you transport a patient against their will. Okay, so even with good intentions and without proper legal authority, that could still be considered kidnapping. It's rare now, but it is possible. Usually, you're gonna get hit with a lesser charge, which is gonna be your false imprisonment instead of kidnapping. Because false imprisonment, again, is going to be more of a common civil claim, but it means essentially the unauthorized confinement of a person. Okay, it's like keeping someone in an ambulance who has clearly refused care, and is capable of making their own medical decisions. So the bottom line here is that if a patient refuses care and they're competent, you got to let them go. Holding them against their will, even just locking the doors on the ambulance, that could lead to a potential lawsuit. The only exception here is if the patient is mentally impaired, if they're suicidal, or if they pose a risk to themselves or to others. You may be justified in restraining or transporting them, but again, it has to have a law enforcement and medical direction support, because again, you need to have them on a psychiatric hold. Defamation. Okay, so this is the act of communicating false information um, about someone that harms their reputation. Okay, there really are two types of defamation. You have slander and libel. Okay, libel is a written defamation, so such as a patient care report, and slander is just spoken defamation, like during a casual conversation at the station. Um, a real world example for is like, let's say you write your patient care report, and you write your narrative like, oh, patient is like faking their symptoms, and it turns out they weren't, and that statement harms their reputation. Now, that's when you could be sued or liable. Now, how do they get that information? That is a whole nother story. But if it did get out, that's what would be the issue. Or let's say you tell your coworkers, for example, that a patient was, probably on drugs when there's no proof. That was what we would call slander, and it could come back to haunt you because, especially if it's overheard or repeated. Even if you think it's just a joke or you're just venting, you got to keep patient information professional, accurate, and but above all else, confidential. Okay. So if it doesn't help the next provider with care, it probably doesn't belong in your report. So, or in your conversation for that matter. So avoiding defamation, it really just isn't about the legal safety. It's about maintaining trust and professionalism, really in every interaction you have. The Good Samaritan Law. So this is actually designed to actually protect people, including EMTs, who voluntarily render aid in emergencies. Okay. The key word here is voluntarily. Okay. These laws primarily only apply when you're off duty as an EMT and not being compensated, so you're not getting paid for your services. So the basic idea here is like if you stop to help someone in what we call good faith, like performing CPR at a grocery store, you generally won't be held liable for mistakes as long as you acted in good faith, without expectation of payment, within your scope of training, and without what we call gross negligence. Okay. But again, these laws will not protect you if you were on duty or getting paid for your services. So if you're acting as an on duty EMT, you're held to a higher professional standard of care. But also, the Good Samaritan protects the protections vary by state. So if you're ever curious, just make sure to learn, like in California, what actually are you protected from as an EMT, whether you're on duty or off duty. Um, so let's I'm sure you have the questions, like let's talk about gross negligence and sovereign immunity. Okay. Gross negligence really refers to actions that show a willful or reckless disregard for patient safety. Okay, a good example is this: like, let's say you attempt a skill that you never learned and seriously harm the patient. Okay, that could be considered gross negligence. And the Good Samaritan protection won't apply. I always use this example. You've probably seen in the movies where like someone's choking and they like take a pen and they stab the person in the throat to kind of create that opening. That is not something that you were trained to ever do. So if you decide to do that, that would be considered gross negligent. Okay. Sovereign immunity. So this applies to EMS systems run specifically by government agencies. Okay. So this law may limit how much you can actually be sued for, or in some cases, whether you can be sued at all. But let's be clear. Immunity isn't a shield against poor care. Okay, if your actions are negligent, if they're unlawful or just outside your protocol, you and your agency can still be held liable. Okay, that's why it's really important to always stay within your scope of practice, document everything you do clearly, follow local and state EMS law, and really know your protocols and when to call medical control. Because acting professionally and within your training is really always going to be the best protection for yourself, both legally and ethically. Your patient care report. So your patient care report. So your PCR is definitely more than just paperwork. It's a legal document. Okay, it's a medical record, and it's a safeguard for yourself against litigation. The golden rule, and I talked about this in class. If it wasn't documented, it didn't happen. Okay, so courts and hospitals will rely so heavily on your documentation to determine what care was provided, what was observed, and what was said, and really whether the proper protocols were followed. An incomplete or a messy patient care report can suggest an inexpert or negligent care. Even if what you did in the field was appropriate, conversely, a well-written report tells the story of the call. It explains your decisions and it protects you in court from disciplinary reviews. So your PCR is also vital for billing, data collection, quality improvement, and under HIPAA, it becomes a permanent part of that patient's medical record once it's actually submitted. So the National EMS Information System. So this is actually a nationwide database that collects and standardizes your patient care data across the country. This is where that electronic patient care reports are really coming into play. So why does that actually matter? It really matters because your reports contribute to the research on EMS practices. It's about protocol improvements, identifying public health trends, quality assurance benchmarking. So your documentation helps inform regional training needs, equipment decisions, and in some cases, policy changes. It also allows agencies and regulations to track performance, patient outcomes, and safety concerns. So how do you write just like an excellent report? It's all about being accurate and objective. It's about sticking to the facts. Avoid speculation, slang. You only want to use clear medical language. Include all of your assessments, your interventions, your refusals, your handoffs. You want to be as detailed as possible. Now, it is more time consuming, but again, at the end of the day, your information that you're providing is going to be so beneficial to the career and to medicine itself. Okay. When you're also in your patient care report, you're going to have to note the time. So, what time were you dispatched? What time did you arrive on scene? When were certain interventions implemented? When did you transfer care? When did you arrive at the hospital? All that fun stuff. because years from now, your patient care report might be used in a legal case. So will it reflect carefully, compassionately professional care? And if so, it's doing its job and it's protecting you. Again, it's going to be very hard for you to remember a random call on a random Tuesday, 3 years ago. So having that patient care report is also going to be your memory of the situation. Um, Let's turn our focus now to mandated reporting. So these are mandatory reporting requirements. These are legal obligations placed on healthcare professionals, including the EMTs, to report specific findings. Okay. Now, every state requires certain incidents to be reported really to protect the vulnerable populations and to support public safety. So some of these include child abuse or neglect, right? So if you have a call and you suspect physical, emotional, sexual abuse, you are required by law to report it. Even if the child denies it or the patient objects, delayed reporting can result in harm to that child and legal consequences for you. So it's not so much you're just going to report it to your supervisor or to the hospital staff. You actually have to get in contact with, in this case, CPS, Child Protective Services, and make a report about it. Another big one is going to be elder abuse and neglect. Again, these are vulnerable populations because just like children, these older adults, especially those who are dependent or in long-term care, these are protected. These individuals are protected under mandatory reporting statutes. So again, look for signs of bruises, of malnutrition, fear of caregivers, poor hygiene. Because that's another situation where you need to report it. You would also want to report any injuries related to the commission of a felony, right? So this includes like gunshot wounds, stabbings, injuries that are sustained during like assaults, criminal acts. Those also must be reported by law enforcement or to law enforcement rather. Even if the patient refuses, like you're still going to report that stuff. The other one is drug related injuries. Now this one depends on your specific state law. Some states mandate reporting overdoses and poisonings. Others view this addiction as a health issue and protect the patient's privacy. Always know your local statutes. But again, when in doubt, document thoroughly, notify your supervisor, medical control. It's better always to ask the questions than to miss a legally required report. So some of the additional events often fall under mandatory reporting. An attempted suicide. So if a patient has attempted suicide, expresses suicidal thoughts or ideation, you really must notify law enforcement or a mental health crisis team. These individuals are considered unable to rationally or to make rational decisions, and they may require protective custody. Dog bites, right? So in most states, dog bites also must be reported to animal control or a public health official of some sort. Even if the bite seems minor, this is going to help track rabies and dangerous animals. Communicable diseases. So you're not necessarily diagnosing diseases, but if a patient mentions like tuberculosis, hepatitis, meningitis, or if there's a confirmed case, it may trigger a mandatory reporting situation. Local health departments often track outbreaks these ways, so they can kind of stay ahead of it. And lastly, assault and domestic violence. This one's kind of complex. Some states require you to report all suspected domestic violence, while others require the patient's consent, really unless the life is in danger. If the patient is in immediate danger, especially if it's a child, an elderly patient, or just a dependent adult, reporting is typically mandated. But again, always document your findings, your suspicions, and your conversations carefully because you're not expected to investigate abuse. You're really just expected to recognize it and then to report it. Okay. Um, Finally, here are a few slides, or rather, a few situations that may require reporting. Again, just a couple extra little more little ones. You have sexual assault and rape. Okay, so again, most states the decision to report lies within the patient, but especially in adult cases. But in cases of involving minors or elders, usually you are required to report even without the consent of the patient. Okay, so check your state law, ask your supervisor, your medical control, and of course be sensitive to the emotional needs of the patients in that situations. Exposures to infectious diseases. If you or your partner are exposed to bodily fluids, from a patient known or suspected to have some type of communicable disease, again, it must be reported. And then again, follow your agency's exposure treatment plan. Transporting a patient in restraints. Again, some regions, transporting patient in physical or chemical restraints must be documented and reported, especially if the patient is in law enforcement custody. Crime scene evidence. If you respond to a scene that may involve homicide, assault, or any suspicious activity, again, preserve evidence. Notify dispatch, avoid unnecessary contamination, and document everything. Okay, let law enforcement and the medical examiner do their job. Your role is really to provide care and maintain scene integrity. Okay. These reporting obligations really protect both the public and you as a provider. They ensure accountability, and really they reflect your duty to act in the best interests of those who cannot always speak for themselves. Let's shift. We're winding down, so let's shift to the legal requirements. Like away from legal requirements, and more go to the ethical responsibility. So ethics refers really to the principles of right and wrong, right? That guide your behavior. As an EMT, your actions really must be honest, compassionate, and patient-centered. And really got to be consistent with professional standards. You also have to have an obligation to your coworkers, your department, and the public. Your behavior, both on and off duty, reflects the integrity of the EMS profession as a whole. So two key terms we have here is like morality. Okay, so morality is like this is your personal code of conduct, right? It's typically shaped by your upbringing, your culture, your religion. You then have applied ethics. This is how you put ethical principles into practice in the field, even under pressure, okay? Because you're going to face a lot of real world dilemmas. Should you resuscitate a hospice patient whose family gives conflicting instructions, right? Should you speak up if your partner falsifies documentation? Should you allow your personal beliefs to influence care? So in all these cases, the patient's welfare should always come first. So again, follow your agency's code of ethics, consult medical control, or a supervisor if you're ever unsure on what to do in these kind of ethical gray zones. So how do you make ethical decisions in that moment, right? You always have to start by asking yourself the questions in like this ethical checklist, right? Is this action like in the best interest of my patient, right? Am I acting logically and not emotionally? Does this protect the patient's rights? Would I want the same decision if I were in their position? Can I defend my decision to my agency or in court, right? These questions really help ground your choices in professionalism and integrity, okay? So remember, you are accountable for your own actions. So even when you're under pressure, that means that means speaking up when you see unsafe or dishonest behavior, reporting medical errors, like including your own, maintaining confidentiality and dignity, being fair and impartial, regardless of a patient's race, background, or choices. EMS is not just about technical skills, it's really about trust. Patients, families, and the community, they really must be able to count on you to do the right thing. See, even when no one's watching. Ethical providers are really the heart of what a great EMS system is, right? And ultimately, ethical care is the kind of care you'd want for yourself and your loved ones. Even with the best intentions and care, you may one day find yourself in court, okay? Either as a witness or a defendant, right? And you might ask me why? Because EMS documentation is often used in civil lawsuits where someone sues for damages like injury or wrongful death. In criminal cases where your report or testimony is part of a police investigation, or even in a coroner's inquest. This is when your notes help determine a cause of death. So if you're ever called to testify, your role is simply to stick to the facts, right? You're not there to take sides. You're not there to take sides. You offer opinion. You don't speculate. You just explain. What did you see? What did you do? What did the patient say? And what did you document? Right? And here's the key, like everything you say in court will likely just be based purely off of your patient care report. So that's why having a detailed, objective documentation is your best defense, right? So before your appearance to court, always notify your agency leadership and legal counsel. Okay, review your report, refresh your memory, and just remain calm, respectful on the stand, and even under cross-examination. When you're subpoenaed, meaning you're legally ordered to appear in court, you must immediately notify your EMS agency or your director. Uh, Notify the legal team, the risk management office. If you're a witness, your job is usually to testify neutrally and just factually about what happened on scene. This is going to include your observations, the care that was provided, the documentation, and really any relevant communications like with medical control. You really want to avoid guessing. Don't offer any clinical conclusions unless you're asked and you're qualified to do so. Yeah, unless you're asked and qualified to do so. Yeah. So again, before you, oh, I'm gonna sneeze. Excuse me. So again, simply explain just what you did and why. Okay. So, as I said, before you testify, review your PCR. The event may have occurred months or years earlier, so your documentation may be the only memory you have of that call. And the other thing, and the only thing that's really going to protect you from scrutiny, right? So another reason to ensure every report you write is professional, complete, and legible, right? The courtroom may not be where you want your writing to be reviewed, but it's often where it matters most. So make sure it is professional, complete, and legible. If you are in the court as a defendant, meaning someone is suing you or accusing you of wrongdoing, things get a bit more serious, right? In a civil case, the plaintiff, that's the person bringing the lawsuit, they have to prove they have to prove negligence, right? They have to prove you had a duty to act, a breach of duty, there was harm, and there was causation, okay? Your defense may include a statute of limitation. So the deadline for filing a lawsuit has passed. Maybe governmental or sovereign immunity. You work for the public agency, you may have, the ability to have limited lawsuits against you. Contributory negligence, meaning that the patient's actions actually contributed to their own harm, such as like, a patient lied about having an allergy, and that led to an adverse reaction. That may, in and of itself, reduce or eliminate your liability. But even so, the legal process can be long, it can be stressful. So, most EMS agencies provide legal representation for their employees. But again, you must cooperate fully, professionally with that specific defense team. Some also would say get your own defense team. It really just depends on the situation, but that's for another time. During a an actual lawsuit, both sides go through a phase called discovery, right? This is where the attorneys gather information to actually build their case. Discovery tools include like interrogations. These are going to be written questions you must answer under oath. Depositions. This is like a live interview under oath. Usually it's recorded. Request for documentation. This is like where you're gonna you got to get your patient care reports, agency protocols, training records. You may be asked questions like, what were your qualifications at the time? Did you follow protocol? What was the action within the scope of practice? At this point, your credibility is really everything. So if your answers contradict your patient care report or your protocols, it's going to hurt your case. And even if you provided excellent care. So that's why clear, honest reporting from the start is of the utmost importance. And if you ever make a mistake or omission, it's always better to own up to it, to correct it, notify a supervisor. 100 out of 100 times, the cover-ups are always more damaging than the actual error itself. Um, so after the discovery, it's going to come the settlement of the trial. Most civil cases are settled out of court, meaning both sides agree on some type of resolution, often involving financial compensation. But if no settlement is reached, the case proceeds to trial. Okay, and if the court rules against you or your agency, the plaintiff could receive, compensatory damages to cover medical bills, lost wages, pain, suffering, punitive damages like extra fines if the court believes your actions showed like reckless disregard for safety. Now, punitive damages are kind of rare, but again, they're serious. They often follow cases of like gross negligence, like ignoring a DNR, falsifying records, abandoning a patient. A good tip in the courtroom is like always conduct yourself professionally, even if you're angry. So if you're like in this situation, if you're angry, sarcastic, or vague, like while you're on the stand, it really is going to undermine your case and just like your character. But if you're calm and honest and well prepared, you're more likely to be believed and respected. So even if you made a mistake. So like really in short, just let your documentation, your actions, and your attitudes just reflect the high standards of care and integrity that EMTs are really known for. Okay. To wrap it up, this section, by talking about criminal charges, which while rare can arise from conduct in EMS. Some examples of criminal allegations against EMTs include theft of patient property, sexual misconduct, operating an ambulance under the influence, negligent homicide, manslaughter, like following improper patient care or motor vehicle collisions. If you're ever charged with a crime, again, your first step must be to secure like an experienced criminal attorney. Don't just rely on your agency's legal team. Criminal cases carry consequences that go way beyond just like losing your job. They're going to include like fines, jail time, permanent loss of your licensure. Really the key takeaway is maintain professionalism, honesty, compassion at all times. If you're doing your job just according to the training, the protocols, your legal guidelines that we've discussed, the chance of ever facing court, especially criminal court, it's going to drop dramatically. So as long as your care is appropriate, your documentation is thorough, and your conduct is ethical, you're going to stand on solid ground, both legally and morally. That concludes chapter 3. I will see you next time.